talk. Tonight, you're going to be with Ishbel studying gerontology. So over to you, Ishbel.
Thank you very much. I'm just going to share my screen so you guys can see my slides. Okay, so gerontology and studying aging, what is it all about and why does it matter? Sorry, I should put that down. Oops. A little bit about me before we start. So my name's Ishbel. I am doing a DPhil or PhD in primary healthcare, which is the study of non-emergency care. This is actually my third degree and my fourth university. And a fun fact is that I actually didn't want to go to university when I left school. So a little bit about my background. I didn't fail a degree or anything. I just did a year abroad in my undergraduate, which is where my fourth university came from. So I did immunology at the University of Glasgow. I actually started off doing anatomy and physiology, and I changed to immunology when I did a lecture in basic science in my first year there and found out I actually really liked immunology and I wanted to study it more than the degree I'd applied for. And then I also did my third year in the University of New South Wales in Sydney. This was an exchange year, so that in Glasgow, in Scotland, all the undergraduate degrees are 4 years, and I did my third year there, which was so exciting. It was honestly one of the best things I have ever done. But at the end of my undergraduate degree, I finished in the first year of the pandemic, and I kind of was thinking, I don't really know what I want to do. I was looking at jobs. It was a little bit harder because it was the pandemic. Lots of people weren't hiring. So I looked into some master's degrees, and I knew that I really liked the concept of immunology and the concept of helping people and in healthcare, but I actually didn't like the lab work that I was doing. So I found this master's, which was bioscience enterprise, and that was the commercialization of biotechnology and kind of the commercialization of medication and things like that. So I did that, which was a 1-year master's. It was fantastic. I really enjoyed it. I learned a lot about the business and the how to push a drug through clinical trials and all of that side of it. And when I finished it, I thought, oh, I really want to go into intervention development and I want to help older adults. And I was looking at how to do that, how to design my own intervention. And there were lots of different routes. So you could go down a startup, you could join a big company and present your ideas there. Or the route that I went down was I found the primary healthcare department at the University of Oxford, which is where I am now. And I thought, oh, this looks absolutely fantastic. There's a department which is looking at exactly what I want to look at. And the PhD had enough freedom that I could be developing something with the support from all of the lecturers and all of the university, and also use their resources such as their funding and their the department where I could host my interviews and things like that. So it seemed like the perfect route for me. My whole family were completely shocked that I had gone from not applying to university when I left school to doing a PhD and still being here nearly 10 years later. But anyway, I'm going to talk to you about gerontology. Just while we're going, if anyone has any questions, please put them in the chat so you don't forget them and we can cover them at the end, but send them away. So the study of aging, there's 3 parts to it. This can come from a biological perspective, a psychological perspective, or a sociological perspective. And why is this important? So if you guys have a think about maybe your oldest relative or friend or person that you know, do they have any age-related problems or challenges that they encounter? And also thinking about them, so maybe, or if you don't have anyone that you're very close to, thinking about your parents as they get older, how can we make that as pleasant as possible and how can we make them have the longest, best life that they could live? So that's why I'm studying it. Okay, so breaking it down into these 3 parts, the biological side of it is kind of on a cellular level, disease on a cellular level, so looking at the kind of genes and your organs and how a disease actually attacks your body and how your body naturally ages. Then we have the kind of psychological perspective of looking at it. So this is kind of the cognitive side of it, cognitive impairments like dementia and older adult diseases like that, but also the emotional side. So how does a person feel about losing their function and getting older? And then the social side of it. So this could be how an older adult fits into the environment and how it's suited for them, but also how policy is tailored to include older adults. I'm going to talk a little bit about the kind of careers and study choices in these three areas later, but this is just to give you an overview before we go ahead. Okay, so aging has been around forever and it is associated with vulnerability, and we've been trying to fight it for decades and decades and longer than that. So this picture here is from ancient Greek mythology, and it is Hercules fighting Geras, who is the god of old age. And as you can see, he's a frail old figure here, and Hercules is really strong and known for his strength, but he is still fighting this aging and trying to battle with it. So yeah, it's a topic that's really important to everyone. We're all going to get old or know someone that's getting old, and it's an area that has lots of different issues attached to it and lots of different research arms. So it's a very important topic. So here's some proof of the advances that we've had so far. So we have got an aging population because people are living longer. So this first graph here shows that life expectancy in the last couple of decades has significantly increased. So yeah, as you can see here, it only goes up to 2016. After 2016, the life expectancy started to level out, and then recently they've found that life expectancy has maybe dropped to about 2012 levels. And this is because of the pandemic and things like this. However, 2012 is still a significant increase from the life expectancy we had before. So yeah. However, the second graph here shows that that your years of life lived in poor health have also increased. So you can see here it kind of goes from 6 to 8 years of poor health, and from 8 to 10 years of poor health for a female. And this actually, we should be seeing it decreasing with all of the medical advances that we've had. And yeah, we're aiming to reduce this and make sure that people have a healthy end of life rather than living in poor health. So yeah, like I mentioned, people are living longer, but not healthier. And this is often associated with multiple chronic conditions. So what are multiple chronic conditions? People often refer to these as multimorbidity or multiple long-term conditions, MLTCs, and it's defined as the presence of 2 or more long-term health conditions, which can include physical conditions, mental health conditions. These are chronic ones which accumulate over life, so they don't really go away, and they can also include persistent infectious diseases like HIV. So yeah, like I mentioned, they accumulate with age because you don't get better from them. And this means that they're the biggest problem in the older adult age category. So that's why I've decided to research this. Another problem with aging is frailty. So frailty is a term that's used a lot, but it's often misunderstood. When properly used, it refers to a person's mental and physical resilience or their ability to bounce back and recover from events like illness and injury. So as you get older, you get more and more frail, and it's actually used to calculate risk. So quite often someone will be given a frailty score, and that will help the doctor assess how vulnerable they are and what sort of risk category they're in for aging. So frailty is a very helpful score. It's used quite widely across the world. Yeah. Then we'll go into some healthcare costs by age. So this graph here, you can see along the bottom is age going up to 101, and up the top is amount of money. So it's in £1,000. And as you can see, that as the graph goes along the age, there are higher costs. So these are broken down into hospital and community health services, family and health services, pharmaceutical services, capital spending, and just total health spending is the black line at the top. So interestingly, as you can see, it increases with age, but actually the biggest driver of this is the final years of life. So life expectancy varies so much across the world and across the UK. If you live in Glasgow, your life expectancy is around about 70 to 80, and this is 10 years younger than your life expectancy would be if you were in London. So they're significantly more. So the costs are actually associated between your end of life costs, but it's still to do with aging. So I set you guys a task already. You might have got this already. Have a think about some of the challenges an older adult with multiple chronic conditions may encounter when seeking medical help. I'm going to get you to write a few words on a Menti cloud. So if everyone can scan this QR code or go to menti.com and use this code, which is 65004605. I'm just going to leave it up for a minute to get people, to allow people onto it, and then I'll switch to the Menti in a minute.
You can scan it with your phone if anyone is struggling to use that. It's probably best to just scan it with a phone.
Sorry, yeah, I did mean to say that. I'm just going to switch to it now. Great, I can see some people are already responding. Let's see. Just to let you know, the code's still here at the top, 65004605, if anyone is having problems getting onto it. There's some really good answers coming in. A lot of these are answering most of my next slides, but it's fantastic. So you got some good ones there: communication, memory, understanding, I guess that comes back into memory, transport and traveling, medication side effects, that's a good one. Immobility, that's good. Misdiagnosis. Technology, that's a really good one. I'm going to talk about that later as well. Got 127 responses already. Thank you very much. This is great. Lack of support, that's a good one. Age discrimination, yep. Lack of access, immobile, yeah, that's a good one. Arthritis, yeah, lots of different diseases. Lack of family to help. Getting to the doctor, that's a really good one. Shame of frailty, yep. Everything here is really great answers. Thank you very much. We're on 142 responses. I'll give you one more minute. Trouble explaining issues, yep. Financial constraints, that's good. Cognitive impairment, I'm going to talk about that as well. Great, thank you so much. Right, I'm just going to go back to my slides. If anyone just have a last look at this, any last responses? I wonder if we can get to 150. One more. Fantastic. Depression, that's a good one. Communicating the problem, lack of awareness. Okay, fantastic. Stop sharing. Great, thank you so much for those great answers. Just going on to some of the big challenges that I'm going to focus on. So I know a few people said medication and lots of medication, things around that. So yeah, one of the big challenges is negative effects from polypharmacy. So polypharmacy is a term that's used a lot in healthcare and in research, where a patient is on 5 or more medications. And although they might need these medications for all of their conditions and they might be really helpful for that, they do have some side effects and some problems. So often the drugs will have drug-to-drug interactions that can be negative or could cancel each other out. Or else they can have a lot of side effects from the drugs. And if they're taking so many drugs, they can have a lot of side effects and these can accumulate and build up. Another one which might seem, I don't know, to us who are healthy, it might seem like a minor problem, but it is quite important to a lot of the patients, is taking kind of 20 pills a day. It reminds the patient how sick they are, and it's quite a big burden because they have times that they have to take these medications, so they might have to wake up early every morning to take them. They might have to take them with food, they might have to take them before food, and it just reminds them how ill they are. And that comes up as an important patient priority. The next big challenge is the way that the Western healthcare is structured is we're going down a specialist route where you'll have lots of different specialist doctors to treat your different conditions. So you'll have a cardiologist for your heart, you'll go and see a diabetes nurse or doctor for your diabetes, you'll go and see a mental health nurse for your mental health, you'll go and see the respiratory nurse for any respiratory doctor for any respiratory problems. And this is great because you are getting specialist care for each condition. So it has lots and lots of benefits. However, it does have a few down points. So we're moving away from the generalist care, which was a focus on the patient as a whole. So with the specialist routes, having to coordinate all your different appointments at different hospitals or different locations, and having to make sure that you remember to schedule your appointment, remember to do this. It has a lot of logistical problems for the patient, and it is quite hard to manage. And especially the more conditions they have, the more logistics and planning that they have to put in. And another big point to this is the communication between the doctors. So often the patient will get some advice from their cardiologist, and they'll get completely different advice from their mental health nurse. And this is because both of these doctors have their condition as a priority rather than the patient whole as a priority. And so that communication is quite often lost, and it's quite often the patient will get conflicting information. And unless they have someone who is really on it advocating for them, or they're advocating for themselves, it does become quite a challenge. And the last point here is that the more conditions that a patient has, the more vulnerable they are, and the more that these big challenges are amplified. So if they have 5 conditions, they might be on 30 pills, and these 30 pills will have more negative polypharmacy effects, and they'll have harder logistical planning, and they'll have less communication, and they'll have to coordinate more between all these specialists. So it is a kind of challenge that amplifies itself. It's very sad. And so, yeah, why is it important to address all of these challenges? Well, there's the 3 kind of areas. So it's important for the patient side of it because we want these patients to have a high quality of life. We want them to be healthy. We want them to receive great healthcare. And on the doctor side of it, we want the doctors to have less work if the patients are healthier and have a higher quality of life. We want to have less emergency admissions because all of that really accumulates, and it's hard for the doctors and the healthcare structure to manage. And lastly, there's an economic side to this, because if these patients aren't getting optimal care, they're using more and more health services. So that is more work for the doctors, but it is also more money and more financials around that. And likewise, if the patient is more frail or more ill and they're not getting optimal care, they're also going to have other non-healthcare related costs. So they might be unable to work, they might need carers in, they might need ambulances more often. There's just costs that often fall on the patient, not the ambulance, but the social costs often do. So looking at complex problems, which healthcare is a very big complex problem, but also multimorbidity care is a complex problem and aging is a complex problem. They need multidisciplinary approaches. So multidisciplinary is a collaborative approach using different areas of research and different perspectives. So in this example, you'd want to have all of the different specialists' opinions, and you'd want to have kind of nurses and the social carers. You'd want to maybe have the patient's family, because they see the patient on a whole and they really understand their life. And you also, really importantly, you want to have the patient's perspective in this. So yeah, I'm going to tell you about some of the areas that you could maybe study or research or go into within aging next. So starting off with the biology of aging, I know I already mentioned this, so it's kind of on a more cellular level. It's looking at how the diseases impact the body. I did immunology, so that was looking at how your cells respond to disease. And an important part of aging is cell replication. So when your cells divide, the DNA is duplicated, and at the end of your chromosomes, which are multiplied for a cell to divide, at the end of your chromosomes, there's telomeres, and these parts of DNA are not replicated. So the very end of your chromosome is not replicated when it divides, and this is not a problem at the moment because your telomere is quite long, and so every time it divides, it shortens a little bit, and this means that your cells have an expiry date where they can no longer divide. So when the telomere runs out, the cell's unable to divide. And this is a protective mechanism because it's meant to protect your cells from going crazy and replicating a lot like they do in cancer, but it also means that we do kind of have a point where our cells can no longer divide. So there's lots of areas within the biology of aging. You could also look at pharmacology and look at how drugs interact with your cells. So there's lots of areas there. They normally come under biology or life sciences. Then we've got the psychology of aging. So this is quite a big topic as well. It's very interesting. You can look at the kind of cognitive impairments. So one example is how you diagnose dementia, because at the moment, dementia is just diagnosed based on symptoms, so you can never be 100% sure. Recently, they found biomarkers for Alzheimer's, so they are able to test for it. But otherwise than that, there's normally these memory clinics, and they assess how a patient is and their symptoms based on what the GP has said, and then they say, we think this patient has dementia. So there's a lot of space there to make change, where you can maybe design earlier ways of diagnosing dementia, other sort of things to look for in the community, these memory tests. But on the other side of psychology, you can also look at the mental health side and how people feel when they lose function or independence, and how we can improve that for them. Then there is the sociology of aging. So sociology normally refers to social life, social change, and the consequences of human behavior. So this is quite an interesting space for aging, because you can look at how our social structures are set up for people that are aging. You can help inform policy. So a really interesting space is in healthcare, there's a big shift towards digital healthcare. So it's kind of looking at booking your appointments online, maybe having remote consultations, and then also remote patient monitoring. And this is fantastic for the people that are able to do it. However, there are groups which are left behind in this. So it doesn't have to be aging, but older adults are often less able to use new technologies, just because they've been less exposed to them, but also they might have a fear of them. So it's looking at that and looking at the policy around that, and how we can make sure that older adults are included in this, and how we can tailor different things to them. So it might be that they could just phone the GP practice, so they can still get in-person appointments, things like that. And small things like that could make a huge difference to someone's life. The next area is economics of aging. So economics is looking at resource allocation when there is a finite resources, which is very relevant in healthcare because there's not just unlimited resources. So it's a really interesting space because you can look at weighing up the benefits or effectiveness of new treatments and assessing them against the costs and deciding what should be reimbursed either by the NHS or just by insurers or any system like that, and looking at weighing up the benefits and the costs of things. And this doesn't just have to be within medication, it can also be looking at kind of preventative measures and assessing all the social care costs and the non-healthcare related costs, because these all feed into it. So yeah, healthcare economics is another huge field which is really important to older adults. I've probably missed off a few, but those are the main areas. But yeah, we are limited for time, so I'm now going to go on to tell you about my research. Okay, so I mentioned that these patients with multiple long-term conditions, they have kind of 5 or more conditions, and a big problem with that is that they often display general symptoms of decline, and these symptoms are kind of, you don't know where they're coming from, they're non-specific. So these could be things like general pain, they could be fatigue, lack of appetite, lack of sleep, things like that. There's so many of these kind of general symptoms. And these often lead to a delayed response in identifying what's wrong with the patient. And because they're general symptoms, the patient might not know which doctor to call, which specialist to go to, or if it's just a side effect of their medication. And it means that often, if they are at declining health, they often have to seek medical help through an emergency route, which has significant costs and also significant effects to the patient's quality of life, because if they've waited that long, there might be irreversible damage to them, and it just would have been much easier to intervene earlier for them. So yeah, looking at these general symptoms, and I'm looking at whether we can use them to predict general decline and then intervene there. So going back to this generalist approach rather than a specialist approach. So I'm looking at measuring general decline through changes in physical activity. So can changes in physical activity be used to identify general decline? So this would be asking a patient questions like, did you experience any restricted activity? And then trying to identify the cause of it and intervening. And just once you understand the cause of it, sending them to the specialist care from there. So what do I mean by restricted activity? I mean change in physical activity. So maybe they have difficulty getting out of bed in the morning, maybe they have difficulty getting dressed, difficulty walking across a room. This would be a change to their normal activity. So if they walked 10,000 steps every day, maybe they're unable to do that, or maybe it is as simple as moving from their bed to the chair where they're going to watch TV. It's different for everybody. The measures of physical activity are based loosely on measures of activities of daily living, which is a functional score which has been around since the 70s, and it's used to assess independence. So it's made up of eating, bathing, transferring between bed and their chair, or transferring out of bed, going to the toilet, dressing themselves, and walking or moving around. So these are all the skills that you kind of need to be able to do to be independent. And it's scored based on independent, difficulty with, or unable to do themselves. So there's extensive literature on the benefits of exercise. So people understand that exercise is great for preventing disease. And people also understand that if you maybe go into surgery or you're in hospital, that the effects of this forced reduction in activity are also harmful. So there's a lot of research saying that actually people should be trying to be kept out of hospital because they're still moving, and that's really good for them. However, there's not very much evidence on the natural changes in activity before illness, which is what my PhD is looking at. So the first couple of years I was doing a systematic literature review, which is where I evaluated all the evidence that's already published and already around. And I found that there is evidence to show that older adults experience restricted activity before hospitalizations. So this means that there's a natural decline in activity before periods of illness. And what does that mean? It means that I'm hoping activity changes could be used to detect general decline in older adults. So I'm looking at whether this measure can be self-reported by patients. So self-reported or kind of self-monitoring. For my PhD, I'm looking at the definition of where patients measure something at home without a doctor, and then they report these changes to a doctor. However, self-monitoring is a really broad term, and it's kind of a buzzword in healthcare research, but it can mean anything from virtual wards, which is where a patient that would otherwise be in hospital is able to be kept at home. And often this means there's maybe a healthcare professional going round to their house to check on them, or else they're using technology to feed back to the hospital and they're being monitored there. Self-monitoring can also mean the use of technology to help people monitor disease. So it is quite a broad term. However, it can also be as simple as measuring your weight at home and taking a note of the changes in your weight, which diabetic patients have been asked to do for a very long time. So it is a very broad term. So anyway, my next stage of my PhD is designing an intervention, which is actually the reason that I wanted to do this PhD. So I'm working with patients who are going to be the users of whatever I design. I'm also working with a range of healthcare professionals. So this varies from GPs to the ambulance drivers, pharmacists, community nurses. So it's a big range of healthcare professionals. And then I'm also looking at caregivers. So this could be informal caregivers, which are usually family and friends, and also formal caregivers who are paid to check in on the patient and make sure that they are receiving care at home and able to do the kind of activities of daily living to get by. So the methods that I'm using, my PhD is a mixed methods approach, which is really exciting because it means I get to do some quantitative work, which was where I was assessing the literature, and then I did a statistical test to see whether the measures had any association with the patient outcomes that I was interested in. And now I'm doing qualitative work, which is kind of interviewing and working with the patients. So I'm following the person-based approach, which is broken down into 3 phases. I have some planning interviews, which is the phase I've just finished, where I'm speaking to all of the different stakeholders that I just mentioned and getting their opinion on my research so far and seeing if I've missed anything out, seeing what's important to them. And from this, I'm going to design a very basic prototype of my intervention. And I'm going to show that to the patients and to the caregivers and then to the healthcare professionals again. And while they use it, I'm going to be in an interview with them, and they're going to interact with whatever material I give them, and they're going to speak out loud as they use it. And from what they say as they use it for the first time, I'm going to be able to improve this, hopefully. So I'm going to do a couple of rounds of this, and then very excitingly, my last phase is going to be a little mini trial at home where whatever I've developed from phase 1 and phase 2 will be used by patients at home, and then I will get some healthcare professional input as well. So a really important area of this is whether technology can aid data collection. So like I said, there is this push to shift towards a more digital healthcare delivery because it is easier, and in the long run it's maybe cheaper, but whether it's suited to people is a really important consideration. So I'm going to be assessing different data collections. I'm going to be looking at passive data collection and active data collection. So passive data is where the patient doesn't have to input anything, it's just collected, and it's usually continuous. So I'm going to be looking at smartwatches to collect this. So I don't know if some of you might have Apple Watches or things like that, but it's where a watch can collect data. I'm going to be specifically looking at data on steps and activity, but they can do a range of things like your heart rate and your sleep and stuff like that. And then I'm also going to be looking at active data collection, which is where the patient has to actively input some data. So I'm looking at whether the questions that I would be asking these patients can be delivered through maybe an app on a tablet or an iPad, but also comparing whether a phone call or someone checking in would be more suited to the patients. So here have you experienced a change in physical activity in the last 7 days? And it would be a yes and no, simple tick box, because I'm going to want the patients to, I'm trying to reduce the burden that they're experiencing rather than increase their workload. So yeah, the really exciting part of this is my phase 3, which is user testing and optimization. So I'm going to have an 8-week trial to see how people interact with the intervention at home. So they're going to take whatever, say it's a smartwatch and an app and maybe a paper diary. They're going to take this material home and monitor themselves for 8 weeks. And then at the end of the 8 weeks, I'm going to have an interview with my users and see how they found using it, see what kind of problems they encountered, what they liked. And the results of this trial are going to be discussed in a focus group with healthcare professionals to see if the results are actually useful to them, what sort of data would be more useful to them once it's actually collected, because theoretically asking them, they can't really think of things, but once they have the data, they might be able to identify any other gaps. So yeah, that's the part I'm most looking forward to. Just going back to the kind of post-degree career options for older adult research. So you can go down the route that I've done, where you're staying in academia. You could do further study, like a master's degree or a PhD. And then also, once you finish your PhD, there are still academic careers. So you can go into lecturing, or else you can stay in research. There's lots of options there. You can also go into industry, where they still have research, but you could work for a pharmaceutical company to try and advocate to include older adults or people with multiple long-term conditions in trials, because that's another big problem, is that complex patients are often missed out of the trials because it's too complicated and it blurs the results. You could also work in industry for anything really. You could work for you could work for an app company to develop apps that are suitable for older adults. There's also careers in the medical, like in healthcare settings. So unless you have a medical degree, you're not going to be a doctor, but you could look at healthcare management, healthcare systems. There's a lot of areas there which are really, really interesting, and you can hopefully have a lot of improvement there. And then another option is looking at policy and looking at kind of how to ensure that older adults, like I mentioned, are included in these policies. So you could go and work in government or things like this. So it is a really broad career option. And if it's kind of the area you're interested in, there's a lot that you can do to make change, and that would impact a lot of people's lives, because yeah, everyone gets older. Yeah, thank you very much. That is the end of my slides, because I wanted to leave 20 minutes for questions. I'm just going to go to the chat just now. Please send any questions you have in the chat box. So I've got a question. Have you looked at differences in aging between men and women, such as effects on menopause on older women? I personally haven't, but it is it's a really exciting area, and a lot of people are looking at it. A lot of conditions are maybe women are at less risk until they hit menopause, and then once they hit menopause, there's a shift in their body and they suddenly become at the highest risk because they're because of a hormone change. So yeah, a lot of people are looking at this, and a lot of people are looking at the differences between symptoms in the same disease but in men and women, because that's a really interesting area, is that a lot of the research that has been published is maybe the symptoms of men, and then women are having completely different symptoms. So yeah, very important area of research. We've got another question. Do you think the lifespan of humans could potentially increase in years to come? So I do, and I believe a lot of people are really hoping for that, and a lot of people are, that's their main area of research, is how to reduce aging, how to promote healthy living. I also think that as things, I mean, our life expectancy has increased, and that there has been a shift in the type of conditions that that people have. So initially, things like the cold and flu could just end, like that could kill someone, but now we have more chronic conditions. So there is a shift in the type of conditions, which shows a change in the aging. The next question is, do you think that as the younger generation age, our healthcare will become more technology based? So that's a really interesting question. I do, and I think that as we age, people are becoming more confident with things like online banking, with things like having a remote consultation. People are becoming a lot more confident using the internet, but I do think as we age, there'll be new technologies that will come out, and we might not be aware of how to use them. We won't have grown up with them, so we might have the same issues that older adults are having towards the technology that we're used to using at the moment. But I do think that there will be a digital shift. What factors in particular do you see as effective in increasing the longevity of life? It's a good question. I think that preventative medicine is a really important area that maybe the NHS aren't so good at reimbursing. So I think things like a lot of exercise, a lot of healthy eating, I think these factors are really important to prevent disease. You can see trends in healthcare, and some of the things that are associated with poor health are often poverty, and that can be due. One of the issues with poverty is maybe not eating really healthy food because it's more expensive, and then that means that you're at risk of conditions that are chronic, and then once you have a chronic condition, your trajectory or your likelihood of a healthy life reduces. So I think that is a really important thing, but I think there's a lot more that we could learn about it. So it's an interesting area to research. The next question is anti-aging actually being researched into? Are there any exciting findings? Yeah, so anti-aging is a really big area of research. A lot of people are looking at how we can do personalized blood tests to see exactly what our body's lacking and try and hack aging there. I don't know that much about the exciting findings. I think that there's a lot of science researching it, but whether or not the findings are actually completely true and whether they'll work for everyone is quite controversial. A lot of people are saying that if you have cold showers, that increases your life expectancy, or if you have sauna, if you sauna a lot. There's actually a really interesting Netflix documentary on the blue zones in the world where people in an area live over 100, and there's a lot of research on whether the things that the lifestyle that these people have are actually associated with living longer. And that can be things like in Japan, they eat a lot of purple potatoes. And so people think that these could be a factor for living longer. But yeah, I don't actually know the validity of this research. Okay, next question. If aging is caused by telomeres shortening inside our body, how do chemicals and anti-aging creams make some people look younger? That is a very good question, which I don't think I can answer. There's a lot of cosmetic science research coming out to say that these anti-aging creams can prevent your cells from dividing as fast, but I don't know if it's true. I don't think anyone does know if it is true. I think things like anti-aging cream, things like face cream are probably just good for your skin in general, rather than actually reducing the aging. Do you think that research into increasing life expectancy should still take place when we are still unable to provide the elderly with adequate healthcare and infant mortality rates in some countries are still high? That is a really good question. I think that we should be looking at how to improve quality of life rather than just life expectancy. And that quality of life can be a range of things, but I think if we're just increasing someone's life expectancy, but they're in hospital for the last 10 years of their life and they're unable to communicate and I think that if someone has very poor quality of life at the end of life, it can be quite hard for their family and quite hard for the patient. And I think we should be mainly focusing on quality of life rather than quantity of life. But it is a big debate. And how do you improve quality of life without potentially increasing quantity? I don't know. It's a very complicated issue, but I think it is a very good debate to have. Do you study regenerative medicine? And if so, do you think impact? Oh, sorry. Sorry, I forgot to read that one out loud. Do you study regenerative medicine? And if so, do you think it would have a positively significant impact on life expectancy for humans? So I don't actually study regenerative medicine. My undergrad was immunology, which is the study of your immune system and how your body reacts to disease. It's also the study of vaccines and how to create immunity and how to artificially create immunity. I think regenerative medicine is an interesting space. I think it should hopefully have a positive impact on humans, but anything to try and increase quality of life. And that could be things as simple as exercise. And once you're doing more exercise, you could you become fitter and able to do more exercise, and then hopefully you can increase your independence. But I don't actually know about the scientific side of regenerative medicine. Sorry about that. Would you be able to explain why the life expectancy of females is higher than males on average? Are there any particular factors that contribute to this? That's an interesting question, and it's a debate that people are looking into and looking at the kind of conditions that kill men. So I think a long time ago, people associated life expectancy, the differences in life expectancy from males and females, to do with the males working more, like going out and working, and females staying home. I don't think that argument is that valid anymore, but I think it's interesting. We don't understand if it's on a genetic level, if it's lifestyle level. I think it's probably a combination of everything. Maybe females take less risks and don't do crazy things. I don't know. I think it is an interesting debate, but I think there's a lot of different factors that play into it. So it's probably is genetics, and it also is lifestyle things. Okay, what area of your study do you find most interesting? That's a good question. In my undergrad, I didn't enjoy the lab work at all. I really enjoyed the theory of things and understanding how processes worked. In my PhD, it's a bit different because it's all self-driven. So it's up to me. I decide what I want to research. I decide what I'm going to do what I'm going to do every day and what my day is going to look like. I think my favorite area within my PhD is working with patients and speaking to them to understand what their problems are that they're encountering, and deciding, if I ask them, how can I help your life? They come up with all these theoretical things that could help them, and then I really enjoy putting that down into words and trying to see what can I do to help them. It's also just really nice speaking to people and working with patients in that side of it. Sorry, I've lost which question I was at. There we go. Do you think in the future we will be able to diagnose chronic conditions through technology? That's a good question. I think we already can diagnose a lot of conditions through technology advances. I think that blood tests are becoming a lot better, and we can do them a lot cheaper, and that helps diagnose things. We've had massive advances in cardiology, so we can do ECGs a lot cheaper, and we can do them without such big equipment, which helps diagnose all your different heart conditions. I think it depends on the specific condition and what you're trying to diagnose, but I think that technology will help us, and I hope it makes things a lot more accurate. I mean, cancer technology is also a really interesting space because it's not often quite hard to understand exactly what cancer someone has and where it's come from, because with cancer cells, they often move around your body, and so you could have lung cancer that's moved to your stomach. And I think technology is helping us identify or profile what the cancer cells were and understand how to treat them in a more targeted way. So yes, I do think so. What do you think the impact of an aging society will be on the healthcare profession? And do you think our society is step up for retirement age of 65? How will this shift? That's a good question. So the first half, what do you think of the impact of aging society will have on the healthcare profession? I think we're already seeing this, is that at the moment we're having to decide which beds to allocate. I think the aging population has quite a big impact on it because so I'll just go back to the health economics. How drugs are decided whether they're going to be reimbursed, or interventions in general, is based on quality adjusted life years or disability adjusted life years, which means how many extra years will this treatment or intervention give a patient. And so I think in the older adult space, it's kind of, if they're already really old, it means that when we're assessing if a treatment is feasible, it maybe isn't going to have that many quality adjusted life years. onto their life. So I think a lot of things are being considered when you're looking at the aging society. I also think there's a really big strain on social care, so things like nursing homes, care homes, carers, and quite often we will identify that a patient is able to go home, but that when they get home, who's going to look after them? Are they able to go into a nursing home? And I think that's a really big problem of how do we increase this capacity and how do we make sure that older adults, once they are discharged from hospital, are still getting the help that they need, so they're not just admitted straight away. Because they might be medically able to go home, but once they get home, if they live on their own and they're unable to get out of bed in the morning without assistance, what's going to happen to them? Or they're unable to make their own food, or they're unable to go out to the shops. So I think the impact on the health profession, I think the social side of that is also really important, and understanding what we're going to do with the older adults that are in the community that don't need to be in a nursing home just yet, but they maybe need some extra help. So I think that's an interesting space. And I think it's quite an important topic because a lot of the time that social care falls on the family, and the family are maybe not able to do this, or it has huge impacts on the family and it actually is becoming a big problem for them, but that's not quantified in the same way when we're assessing outcomes. So I think it's a very complex issue, which, like I said, needs a multidisciplinary approach. Good question. Okay, the next one is there a difference biologically in the way different races age, as people of colour sometimes seem to age slower than other races? That is a good question. I actually don't know that much about this topic, but I think there definitely is, especially when you look at how different countries' populations age. So Japan have had an aging population for a lot longer than us, and yeah, it's a very interesting topic. I don't think I can do this question justice, but I think it is really important, and I think people do age differently. Next question is, do you think it would be possible to determine the natural life expectancy of someone in the future using genetics? That's a really good question. I don't know whether you could determine the natural life expectancy, but you can definitely, from their genetics, you can understand which conditions they're predisposed to, which conditions. So by that, I mean which conditions that they're more likely to have, or which conditions they have genes that are more protective for. I think there's a lot that you can tell from someone's genetics, but I also think there's a lot that's down to chance and down to their environment and their health behaviours. But I think there is a lot that we can tell, and I think we should still be progressing with genetic testing and things like that. The next question, this may be quite a specific question, but what's your opinion about people who suffer from ALS? Do you think if research improved in the next few years, there may be a permanent cure to it since it's a gene therapy has been introduced? I honestly don't really know that much about it, but I think that gene therapies are going to have, I think that there's going to be a lot of positive treatments to come out of gene therapy, so I do hope so. But I don't think I can answer that question, I'm afraid. The next question is, do the official guidelines which healthcare professionals have to follow change regularly to improve patient welfare? That's a really, really good question. The official guidelines do change, and in theory they should be constantly changing. Whether they change at an appropriate speed to how our research comes out, I'm not sure. I think that a lot of the guidelines are maybe very suited to, like I mentioned, the problem with people with multiple chronic conditions. The guidelines are maybe very accurate for someone that has only diabetes or only one condition, but I think often these guidelines are really not suited to people that might have two or more conditions and how they intervene. I think that the guidelines are there for the healthcare professional to help to support them to make their decision, but I think it also varies between your healthcare professional as well, and whether they understand the patient's life and how that fits into I guess it's more on an individual basis, because these guidelines often are very suited to one person, but maybe if someone else has a lot of conditions, the guidelines aren't suited to them at all. Do you think making nursing homes cheaper and paying care nurses could improve the quality of life and help the elderly receive? That's another good question. So I think it's a debate of whether nursing homes can be made cheaper and paying care nurses to do more. I think it is very important, and I think that this area, I mean, it's something that I'm quite passionate about, because I think a lot of older adults are discharged from hospital because they're medically fit, but they're not independent and they're unable to function living at home by themselves. And a lot of people can't afford to put to have a carer or have a full-time carer or have someone to go in to check on the patient. So I think that better social care could definitely improve quality of life. How we go around that is, yeah, I think yes, it can improve life, and I hope that we can find a good solution to that soon. The next question, I think this is the last question. Do you think that women having shorter health spans than men could be caused by any biological factors? Mostly gender data gaps. So actually, it's men that have shorter health spans than women. I think there probably are biological factors. I think it's a mix of lots of things. I don't necessarily know if it is data gaps. I think there's data gaps in a lot of areas. I think there's data gaps in a lot of research between men and women in disease things, but I think for life expectancy, I think it's just a mix of lifestyle factors and biological factors. Thank you. Do we have any other questions, or
I think
people can
that's
go away
all.
in 5
One
minutes?
more. One more.
Oh, one more.
Oh, that's not a technical question. I'll let you read it.
I guess women having more estrogen increases their life expectancy by reducing. That's a good point. Yes, until they hit menopause, and that was one of the conditions where once a woman hits menopause, they're actually at higher risk of cardiovascular disease. So it protects them to a certain extent, and then it stops protecting them. But I think there's a lot of complex research in between the different genders healthcare. And I think it's very exciting that a lot of people are now researching this, and there is a lot more evidence and a lot more data being produced on it. That's an interesting space. I think that's all the questions.
Yeah, I think that is. You've done a fantastic job in answering all those questions, and it's really, really good that everyone has had so many questions. It's been really, really interesting listening to your talk, and also the quality of the questions coming through has been fantastic. Very quickly, Ishmael, is there anything you would recommend to people who are potentially starting out and they're looking to go into similar fields to you in the future? Is there anything you would suggest that they do or read or look at that would help them in terms of getting bigger awareness, or even just out of interest, they found this interesting? Is there anything you can point them towards?
Yeah. So I think what I was trying to get across in my presentation is that aging is such a wide topic and it spreads across all these different areas of research. So I guess my biggest piece of advice is find something that you want to change and that you're passionate about improving. And then you can look at the problem from all these different areas and see what you're most interested in. I think another important thing is if you are really interested in improving older adult healthcare, I would try and volunteer at a kind of old person's home or an elderly day centre or something like this, because those organisations are always so short of staff, and it is really, really interesting working with the patient themselves, because you can read about it, but you're never going to understand what it's like to be old until you are old. So I think that really helped me to understand their perspectives. On that note, it's also really good for your CV when you're applying to university to say that you actually have experience and you know that you're able to have the emotional and physical, like, it's very draining working with an older adult who, sorry, my Siri is just on. I must have, like I said, sounded like Siri. Yeah, I think it's important to show that you are able to have the mental capacity to work with older adults, and that you're able to emotionally be prepared for that. So I think it is a very good thing to have on your CV if you are applying for a healthcare studies, healthcare area. That's my biggest piece of advice, and it's good for you personally. I'd say it really opens your eyes to some of the problems, and you might find something that you're passionate about when you're doing that. You might see an area that you think you could improve.
But with that, I think we'll wish you all good night. Thank you again, Ishbel. Like I said, it's been really interesting sat here in the background. But yeah, thank you all for coming, and thank you for great questions.
Yeah,
Bye,
thank you so
everyone.
much. I found all your questions really interesting.